Okay, well, thanks everyone for being here. I really appreciate the opportunity to chat with other like-minded people. It's always fun for me to, because I learn from you guys so much. I just a little background about me. I grew up in Southeast Pennsylvania, deeply embedded in the horse world. So that's where my sort of love for performance medicine started, was with my own performance horses. I ran an operation there for about 10, 15 years. I did all of my schooling in Pennsylvania and then did my rotating internship down in Florida last year. And now I'm with Dr. Fry here at Cornell. It's a 3-year residency program. I'm in my first year. So I'm thrilled to be here to learn from him and to bring you guys a little more information in case you ever need it. So regenerative medicine is a broad term. The Mayo Clinic has this definition that I really liked, defining it as a branch of medicine that develops methods to regrow, repair, or replace damaged or diseased cells, organs, or tissues. So it's quite broad. So we have a lot of room to do a lot of cool stuff within this umbrella term. And this image I found from a human paper, it just illustrates sort of how we have regenerative medicine on one side, which we're going to talk about today, of course, and how we sort of pair it with rehabilitation, whether that's exercises, modalities, things like that. And together, those two things combined give us a really great way of optimizing clinical and patient outcomes. So what we're actually going to talk about today, the main 2 points are the platelet-rich plasma, or PRP, and mesenchymal stem cells, or MSCs. These are the 2 procedures we do at Cornell, so they're the ones I am most familiar with from a hands-on perspective. The other ones I'm going to mention, these other biologic treatments sort of listed down here, they're not things we offer at Cornell, but depending on which veterinarian you go to, which sports medicines person you see, some physiotherapists, these might be things that are offered to you. So I wanted to give you a little information about what they are, and we'll talk a little bit about how they differ from these top 2. But the 2 therapies we're mainly going to focus on are these top ones. I tried to select my images with care. However, there are some images and videos involving needles and blood. I will try and give you a warning. However, since I do this so often, I'm a bit desensitized to it. So if I forget, I do apologize in advance. And since I'm among friends of other crazy dog people, you get to look at lots of pictures of my dog. So the 4 basic things about each of these treatments we're going to talk about is, what is it? How does it work? When do we use it? And giving you some examples. So we'll start with platelet-rich plasma, our first regenerative medicine therapy. To really understand what we're trying to achieve with this therapy, we first have to understand what a platelet is. So if you throw your mind back to your basic science classes, high school, college, whenever, we can remember that platelet is critical for clotting. If you unfortunately know anyone that has thrombocytopenia or something like that, which is a condition of very low platelets, you know, they're always worried about bleeding. So the platelets are made in the bone marrow. The bone marrow makes these large cells called megakaryocytes. They look sort of like octopuses, where they have this big round blob in the middle and then sort of these tentacly arms that branch off from it in all these different directions. And these tentacle arms are chains of thrombocytes, and thrombocyte is simply the medical word for a platelet. And so they sort of grow on these chains and then they sort of bud off as they're needed. If we look to the left, I have this little schematic and image. At the top, it just shows you a size comparison. So the donutty looking thing on the left is our red blood cell. It's sort of indented in the middle, but it's nice and round. This dumpling looking thing is a white blood cell, and this little squeaker in the middle is a platelet. So you can see it's much, much smaller than the other 2 components of the blood. So if you were to collect whole blood, you know, straight out of a vein, or if you cut a finger, things like that, the majority of your blood is actually made up of plasma, which is the liquid component of your blood. It tends to be a little bit yellow in color, not drastically yellow, and depending on the species, that color of yellow can vary. But the plasma makes up about 55% of your blood volume. And then as far as the actual cells within your blood, red blood cells make up about 40 to 45%. So again, your red blood cells are zooming all over your body, delivering oxygen, taking away carbon dioxide, nutrients, waste, all that good stuff. They're really important. after red blood cells, the number really drops off. So if you're looking at your white blood cells in, a mil of whole blood, it's about 1% is white blood cells, and platelets are less than 1%. So since we're trying to select for platelets, you can see that we have to go through a bit of a process to isolate them. And I just think this this cartoon is funny. It's something from one of my lectures in vet school that I've just saved. So PRP, the definition of it is, again, very vague. So it's simply a solution that contains more platelets than the whole blood from which it is made. So whatever factor will qualify as PRP. So if you have 2 times the number of platelets in your solution compared to the whole blood, that's PRP. If you have 10 times the platelets in the solution compared to whole blood, that's also PRP. So there's a lot of variability in what is defined as PRP. So what are we actually trying to harness within this platelet-rich plasma? So inside the platelets, there are these alpha granules and dense bodies. Again, this is an image from a human paper, but it serves my purposes. And within these alpha granules is stored something called growth factors. So all the GF at the end of these things, it's all growth factors. Think of them as like little proteinaceous messengers that run around the body delivering various messages. So these alpha granules hold these different growth factors, and you can see that there's tons of other stuff in these various little dense bodies and alpha granules. But for our purposes, these highlighted ones are the ones we really want, because these guys, if we place them in an area, tend to have an anabolic effect. They can decrease inflammation, and of course, where there's less inflammation, there's less pain. And there's some research that might suggest there's some antimicrobial properties, but we're not really using them for that. We really want them for analgesia, so reduction of pain, decrease inflammation. So the way we make platelet-rich plasma, we collect blood right out of a vessel. We then put it in a centrifuge and spin it down. And based on the weight and size of different things, they'll sort of separate out in the tube. So at the bottom, you'll have your most dense, your red blood cells. Then you'll have this sort of middle buffer area that has platelets. And then you'll have the plasma all the way at the top. And then we collect just this top portion. Of course, we don't want the red blood cells. And then this is the solution that's called PRP. And we inject it into whatever site we are currently treating. Now, we use commercially made kits to prepare PRP, but there's a lot of different kits, and there's many different characteristics that these kits make when they make a PRP. So I have to sort of sort through and decide what is most important to me, what am I going to focus on, and choose my kit accordingly. So depending on the various product, they might make a different volume of PRP. So again, if I'm treating a Yorkie, the amount of PRP that I will need is a lot less than if I'm treating a Newfoundland or a Great Dane. Even though I can inject the knee of both of them, the volume that I can inject is very different. The concentration of platelets. So even if a particular kit makes 10 mils of PRP, but there's not a whole lot of platelets in it, it's not as useful to me. And last but not least, and for me this is really important, is how many red blood cells and how many white blood cells are within this particular PRP that we're making. I really don't want any red blood cells or white blood cells. They both increase inflammation. So red blood cells in particular, in vitro, so again, in a laboratory setting, have been shown to stimulate inflammation and increase the cell death of human synoviocytes. Synoviocytes are the cells that sort of line the joint capsule and joint area. So I really don't want to be killing them. And again, this was done in human cells and in a laboratory setting, not in a live animal, but we know that they cause inflammation. So we still don't want red blood cells in this PRP solution. White blood cells, there's a correlation between inflammatory cytokines. So those inflammatory messenger molecules, they go up if you have more white blood cells in your solution. So again, increasing inflammation, something I am actively trying to reduce. So you guys do not need to read these tables closely. I'm going to sort of summarize for you. As a dog training group, I'm sure you guys are familiar with VOSM, Dr. Knapp's practice down in Maryland. This was a paper that was done between his hospital and a hospital in Las Vegas. And they took 5 different commercially available PRP kits and they prepared them exactly as the manufacturer directed. And then they looked to see how much platelets, red blood cells, white blood cells were in each of these kits and sort of compared them. So this middle chart here is all about how many platelets are in each microliter of blood. So the blue in each of these charts is whole blood, and then the green is in this chart platelet PRP. So again, system 3 has a ton of platelets. System 2 doesn't have that many platelets, but you can see there's a huge variety between these kits. Same if you look down here, this is red blood cells on the left, white blood cells on the right. You can see there's a vast difference in how many white blood cells and red blood cells there are in each of these different kits. Lastly, this chart at the top, it's talking about what volume of PRP does each of these kits make. So that's why I've circled in red here. And this looks at how much blood is needed. So again, if I'm pulling from a Chihuahua versus a Great Dane, I don't want to pull as much blood from the Chihuahua as I can pull from a Great Dane. Also, the more blood you're trying to pull, the more likely you are to lose your entry into that vessel. So if any of you have ever seen a vet trying to pull blood from your dog, they'll call the vessel blowing, meaning they're no longer in the vessel. So if you're collecting a larger volume of blood, you might need to stick the dog more than once, as opposed to if you're only drawing a very small volume. And looking at like how much PRP each of these kits makes, it's vastly different, anywhere from 4 mils to 10 mils. To put this in another context, about 15 mils equals 1 tablespoon, 1 US tablespoon. So when do we use PRP? Joint disease, I have lots of different cases where dogs can't go to surgery for various reasons, for like knee injuries, so ACL, CCL tears. We'll use this a lot for them. Synovitis, bursitis, tenosynovitis, inflammation of various things. So bursas are like these little fluid-filled balloons that cushion tendons as they go around sharp prominences. Synovitis, of course, we talked about sort of the lining of the joints. Issues with tendons, so tendinopathies, desmopathies, and enthesiopathies are like where tendons and ligaments attach to bone, and muscle strains. So all of these different conditions we have used PRP for. So this is a chart I borrowed from Dr. Fry's presentation that he gave to a whole bunch of veterinarians last year. And all these different studies looked at PRP. They were injecting many different joints. And the big takeaway I want you guys to remember from this is just how long did they see a positive effect. So we inject a dog somewhere, one of the various joints, and we want to see a reduction in pain, a reduction in inflammation. We want to see them clinically more happy, more willing to do things at home. And the positive effect on average is about 3 months. However, you can see in this chart, some of them go up to 6 months. So our first example, this is not a patient I have personally seen. This is a case that Dr. Fry saw, and I borrowed some of his videos. So this is an 8-year-old Doberman pincer. She had a torn cruciate ligament on her left side a year prior to this video being taken. She did have a TPLO surgery done then. However, for the last 2 months, she has been lame on her right leg and has been diagnosed with another cruciate tear. During this year, she has developed DCM, which is dilated cardiomyopathy, which unfortunately is a very common heart disease in Dobermans. So she is not a good candidate for anesthesia. Her owner didn't want to take that chance, so she can't go to surgery for her right knee. And we did an NSAID trial. I think we gave her carprofen, and she had really bad GI upset. So I'm going to play this video just so that you can see her walk. She's got that pretty classic bow-legged stance in the back. And I'll play that once more. Her left leg had the surgery, but is still abnormal. We knew there was going to be arthritis there. And then you can see She's really placing that right hind leg much further from the center of her body. She's not putting as much weight on it. So we wanted to help her, and our more conservative methods of rest and NSAIDs wasn't enough to get her comfortable. There we go. So her owners decided to go ahead with PRP. So we prep an area of the neck. This is where we pull blood from. It's completely sterile. You can see we draw with sterile gloves. This area is shaved, prepared. She is sedated, so she doesn't mind that we're sort of holding her in this position. And we will collect blood into this double syringe system, which is from the kit that we use. And this kit needs about 15 mils of blood. And we'll just pull back nice and slowly. Then we pop it in the centrifuge and we spin it down. So this is what it looks like when it comes out. So here are all our red blood cells down here at the bottom because they're the most dense. This is my PRP up here. And there's this second syringe system. So I keep it on a flat level surface and I pull up on this plunger. This white filter moves down and we pull up the PRP into this second syringe. Most of our injections are done under ultrasound guidance. I like to know exactly where this needle is going. So we like to get images of the area for our own knowledge and teaching, as well as directing the needle exactly where we want it. So here you can see, again, we're injecting a joint. So this is a completely sterile procedure. You know, the knee is shaved, clipped, sterilely prepped. We're wearing sterile gloves. The ultrasound is completely sterile. And you can see they're catching an image on the screen in the background. And then once we know exactly where we are, we introduce this needle into the joint. The analogy I've often been told is it's sort of like shooting a gun. You line everything up and you go straight down over the edge of your ultrasound so that you catch the needle exactly as it goes into the joint. And then we pull back to make sure that we're in the joint. We're looking for joint fluid to come up into our syringe. So that's sort of the yellow fluid you're seeing. Joint fluid is kind of sticky. If you were to put a drop of it on your gloved finger and sort of put your thumb and forefinger together and then spread it out, it'll actually sort of stretch between. And depending on how inflamed the joint is, that viscosity will decrease. If you think of the joint as sort of a balloon with water in it, we want to remove a little bit of joint fluid prior to putting in PRP. I don't want to stress that joint capsule any more than I have to because that's quite painful. I don't know if any of you have personally had a joint injected, but it's really painful when they introduce more fluid into an already swollen knee. So this is sort of dual purpose to make sure we're in the right place and to remove some of that fluid prior to putting in more fluid. If I can direct your attention to these images on the left, down here is a normal dog knee. So this is the tibia over here. This is the femur. And this little band is our cranial cruciate ligament. Or sorry, the caudal cruciate ligament, sort of bridging between the two. This image in particular is looking at the insertion point. So this is a normal knee. And you can see this is nice and dark, all good. This is our Doberman's knee. So we still have the two bones, obviously, but there's no nice ligament arching between the two. And all of this sort of looks like seaweed or wispy clouds. So this is a pretty angry, inflamed knee. So once we have affirmed that we are in the joint, we will change the syringe. We will leave the needle in place and attach our PRP and gently inject. It should go easily. If it takes effort, we're probably not in the joint anymore. And they're just capturing a video of the PRP going into her joint. All right. So the next case I'm going to tell you about is Mr. Cooper, who is a total love bug. He's a 1.5 year old male neutered lab mix. As a puppy, he did have panosteitis, which is that sort of inflammation of the long bones. A lot of people call it growing pains. He responded to rest and NSAIDs. This was in December of 2019. He was diagnosed with elbow dysplasia in June of 2020, and there's many different things that fall under the umbrella of elbow dysplasia. For him, he had fragmentation of the medial coronoid process, which is a part of the ulna bone, and there was incongruity between his radius and ulna bone. And due to these uh, things that were wrong with him, he'd already started to develop arthritis.
Oh, just a
Yeah,
pain.
yeah, it was unfortunate. So he went to surgery at the end of June. His left side was the worst one, so they chose to do surgery just on that side. So they went in and debrided the medial coronoid process, removed those fragments, and they removed a portion of the ulna to try and improve that congruity. After surgery, he still wasn't that comfortable, so in September, he had injections of steroids and HA, hyaluronic acid, into both elbows. At the time of all of this, he was living in Texas, so he came to see me in November of this past year. At that time, he was doing 2 or 3 short leash walks a day. He would play ball, but he would only run, and it was more like hopping rather than running for a few yards, and generally was just very uncomfortable. So I will play this video so you can see him walk. You can see he has a very abnormal
Oh,
front
yeah.
gait, particularly that right front. You see how much he's bending his wrist to try and avoid bending his elbows. You can see
Mhm.
how swollen his elbows are. He also is lame in his hind limbs, but we're just going to focus on his front feet for now.
Poor baby.
Yeah. And his owners just, they're like, we've tried so many things. What else can we do to help him? So, our exam findings for him, he was a 3 out of 5 lame up front, left being worse than right. He was 2 out of 5 lame in both of his hind limbs. On standing exam, he had some pain on his right back portion of his neck. He was very painful on extension of both of his hips. And there's a particular maneuver called an ortolani that we performed that shows joint laxity in the hips, and he was positive for joint laxity. His elbows are obviously quite effusive. If you watched him turn here, you could actually see just on the video how effuse they were, and had very limited range of motion, the right side being more affected than the left. Again, the left side is the one he went to surgery for. Um, Even when he's standing, he doesn't stand normally. He sort of arches his back. He really pops his elbows sort of out away from his body, trying to not put pressure on them. And he really just doesn't want to stand for very long. Even doing my exam, he kept trying to lie down on me. So, talking to Cooper's owners, we made a plan. I know he'd had CTs and x-rays done in the past, but I wanted to do new stuff to evaluate the dog I was seeing at the time, and we had images to compare them to. So, he had CTs done before his surgery back in September. So we took x-rays of his hips because he hadn't had any investigation done for those. He did have mild hip dysplasia on both sides. And we wanted to do a CT. It's really our best modality to evaluate the elbows. And we also wanted to investigate why his neck hurt. Um, so the CT of his neck showed that there was an abnormal facet, and the facet is the articular joint between the vertebrae, sort of how they move. And that was between his fifth and sixth cervical vertebrae. And there showed some narrowing up there, which was abnormal. We're still watching that. And then his elbows, unsurprisingly, we'd seen progression of his arthritis. So he was actually categorized as end stage arthritis at this young age. So our initial plan was go home, we're going to get some weight off of you, we're going to give you some pain medication, we're going to give you some very mild, low impact home exercises. We encouraged his owners to get like a nice big padded orthopedic bed for him to lie on. And we'll have him come back, see how he did with that. He improved a little bit, but not enough. So then we did go ahead and do PRP in both of his elbows. So this is just some images for you guys to see. This is a normal elbow. On this side, the star indicates this is the medial coronoid process. So we're looking at the inside of the elbow. And the medial coronoid process does bear more weight than the other portions of the ulna. So in elbow dysplasia, one of a very common thing to be wrong is fragmentation, because there's like little micro cracks in this area of the elbow, which eventually will fragment. So as I tell a lot of people, fragmentation isn't the cause of the disease, it's more evidence of it. So there was abnormalities going on in that elbow long before fragmentation occurred. And these are just images from a CT showing you some very abnormal elbows. So all these little bony things should not be there. You can see it's just not a happy elbow.
Yeah.
So this is Cooper 5 weeks after PRP. He actually would trot for us now. And his gait is still abnormal. I wish I had a way to turn back time and eliminate his elbow dysplasia and his arthritis. I don't unfortunately have that capability, but he's overall much more comfortable. At home, his owners reported that he now would actually play with his housemate in the snow, and they also noticed that he was much more comfortable. On exam, he had much less effusion in his elbows, and he had much more comfort on range of motion. Again, they weren't perfect. They're never going to be normal, but they were better. He had achieved his ideal weight. The rest of his ortho and neuro exam was pretty much the same. So we were very pleased with this. I think he's due to come back in another month or so to see us again and sort of check in. Right now, we are in the process of weaning him off of pain medication, keeping him at that nice lean weight, and we gave him some more home exercises to work on. And because he's doing well, we said come back and see us in 3 to 4 months. We'll see if we need to do more PRP.
From Texas.
So our next case, Russ, is a wonderful little border collie. So this visit was in December of 2019. At the time, he was a 9-year-old male neutered border collie. He has since retired from competitive agility, but at the time he was still competing. He had an acute lameness after a single jump, and while he sort of responded to rest and NSAIDs for the last 3 weeks, he wasn't back to normal, and he had no prior medical issues. So here's Mr. Russ. All right. So he was left forelimb lame, if you could see the little head bob in that video I just played. And he was quite painful when we palpated the distal, meaning closer to the toes of the elbow, sort of the epicondyle, one of the little bony portions that you'll see sort of here and here. But he had no pain on range of motion of the elbow. So we did a CT, and this little thing was very weird in the muscle here. That's not something we normally see, which was quite strange. So what he ended up being diagnosed with was a strain of the superficial digital flexor tendon, which is what we're seeing here. And then where various tendons attached to these epicondyles, there was some abnormal changes. So that's our flexor enthesiopathy. So our plan was to rest him for 6 weeks to see if this would resolve, and if with less activity, no high impact activity, if his enthesiopathy would resolve. So we continued resting him for 6 weeks, gave him some physical therapy exercises, and tried reintroducing sport. Unfortunately, that was not successful. We tried to be conservative, but we ended up having to do something. So again, we ultrasounded. That's the image you can see here. So here's sort of our elbow, distal meaning closer to the toes. This is our epicondyle, and this little bump, not normal. So we did some PRP, and he came back 6 weeks later. So here is his, oh, did not mean for that sound to be on. Here's the first video you saw. And he does have a subtle lameness, and he's a pretty stoic dog, so he didn't really like showing pain anyways. And then this is him in July when Dad brought him back. So he was much better after his PRP, and 12 weeks after, he was back to doing what he loves. And he did well at 16 inches, so they said, let's put him up. And he doesn't care a bit. So that's Mr. Russ. Any questions about PRP before we dive into stem cells?
Yeah. Let's see, chat. Uh, is there any cure for
Ask a question?
Judy, was that you?
Yeah.
Go ahead.
So when you have a successful treatment, as in Russ's case, and the dog goes back to normal activity, is it damaging to the joint? Is it just stopping the pain, and then could the joint problems continue to be damaged? I'm not quite sure I understand that.
No, it's a great question. So unfortunately, most of these cases are going to be progressive, whether I let them go back to sport or not. So we try and modify their sport if, for elbow dysplasia, it really doesn't matter what I do, that's going to progress. So everything I'm trying to do is to slow it down and make their quality of life as high as possible. In Russ's case, he didn't actually have a joint problem. It was just where those tendons were attaching to the bone. And then he had that little spot on his CT in the muscle. So the muscle healed, and that was the 6 weeks of rest that we did. The muscle was back to normal. And the enthesiopathy, we did the PRP around that to decrease the inflammation. Now, that definitely could come back in the future. But when we very slowly and gradually reintroduce sport, and we have astute owners that know their dogs and are going to tell me when there's a problem right away, I don't have a problem with them going back to sport when it's something that they love. Maybe we change it. And so in Russell's case, he was cleared to go back to full sport. But sometimes I'll say to people, sure, they can do agility, but let's lower the height of the various jumps. Maybe let's try not to do so many tight turns. So spread their course out a little bit. Make sure that they're doing less high impact stuff. So maybe no weaves if they have, a shoulder issue or a wrist issue. So it's very case dependent. And of course, if they have a serious joint problem, I'm not going to be recommending high impact activity. Does that cover your question?
Well, it helps. Yeah, I've not had PRP on my dogs, but I have rehabbed a couple of dogs, and they never went back to agility.
Yeah, it's very case dependent. So I'm afraid I can't make a sweeping statement for every dog, but I always try and get them back to what they love to do.
Okay, thank you.
Of course.
Can this be, like with one treatment, actually curative?
Depends on what we're treating. It can be, yes, in some cases, and depending on what the dog does with its life and its free time. So for some muscle strains, if we use PRP to treat them, and they are, very conservatively managed, and their muscle heals, and once they're finished healing, yes, then that would be the end of it. For things like joint problems, tendon issues, there's a component of progression to a lot of those conditions. So in that case, this isn't turning back time. It's not fixing, if there's barbs of bone that a biceps tendon is rubbing across, I'm not removing them. I'm just helping the patient with pain, reducing inflammation. And we know that in the future, we will probably need more treatments. So it depends on what I'm treating. But I have plenty of patients that we only see once or twice a year for PRP, and the rest of the year they're living their best life.
And in terms of cost, would you always do surgery if the dog is okay for surgery, or would you use this first? And is this cheaper, more expensive? How does that compare?
Yeah. So if we're going to take cruciate disease, just because it's a simpler disease process to talk about, and something that you guys are probably all familiar with. So if you have a dog that comes in with a torn cruciate, unlike people they have that tear their ACL, it's usually traumatic. So soccer players, football players, the ligament itself is fine. They just did something to traumatically tear it. So in people, they'll go in and actually fix the ligament itself. In dogs, unfortunately, that's not the disease process. It's a degenerative condition that slowly weakens the ligament over time. So we don't fix the ligament itself because it's going to tear again if we do that. So surgery for cruciate disease, if you do a TPLO, they're making a cut in the bone and changing the angle and the biomechanics of how the knee is working. And then the bone heals. Bone is one of the few tissues that will heal to its original strength. As long as their bone heals well, they go on and have a great life. They're still going to have arthritis in that knee because there's a degenerative process and a lot of inflammation, but they're generally very happy. They go back to full function, live your life. However, there are certain dogs that can't go to surgery for various reasons. So we talked about the Doberman with the heart disease. Some of our older patients, owners simply don't want the risk of anesthesia. A TPLO is like $4,500. It's really expensive. And if one side tears, if the cruciate ligament tears on one side, most likely they're going to tear the other side. So it's a lot of money involved in going to surgery. So it's a conversation that we have with owners that we'll talk to surgery about. Some dogs are good surgery candidates, some are not. As far as when I use PRP, it's usually what I offer people if they can't go to surgery, because it does help with pain, it does help with inflammation. We can continue rehabbing them with PRP on board. And what we're doing in that case is helping them be more comfortable while the body builds scar tissue around that knee to stabilize it, because we're not surgically stabilizing it. Cost-wise, PRP is much less than surgery. For us, and again, these are rough numbers off the top of my head, I think it's $400 to $600. It is a sedated procedure, but it's reversible sedation. We sedate them for the procedure itself, and then we reverse them, and they wake up and go home the same day. So it's always an option for dogs like that. If some people aren't able to get their dogs into surgery for many months, with the pandemic, there's been a lot of backlog, particularly in elective surgeries. So if they can't get their dog in for surgery for 6 months, maybe this is something we consider to help them with pain control in the meantime.
And I'll ask a third question if no one else wants to ask one. And that's, I know in people, you often have corticosteroids injected where there are joint problems. Is this the kind of problems that steroids were used formally, or is that another option, or how does that work?
Yeah, it's a great question. We do steroid injections quite frequently. There are many cases where we're using PRP where we could offer them steroids. Steroids work a little differently, obviously, as we talked about sort of how PRP works. Steroids, think of it as being injected into an area and smothering a fire. So if your joint is really inflamed, that's the fire. And you put the steroid in there and it quenches the fire.
Right.
And it lasts for 6 to 8 weeks, which is great. It's pretty well tolerated physically, sort of for the rest of the body. So usually at a negligible amount systemically within 7 to 10 days. And, but that's sort of the extent of what steroids is going to do. So they last less amount of time, 6 to 8 weeks as opposed to 3 months. So I usually hold steroids in reserve for when patients stop responding to PRP. Or for like biceps tenosynovitis, if there's like a biceps tendon running along a groove that is really degenerated and has lots of little like bony knobs, and that's what's irritating the tendon. Once that gets severe enough, I use steroids to sort of quench that inflammation. However, again, it's not changing anything else in that space. So I'm not eliminating the cause of the inflammation. So it will come back in the future. So we do use steroids, but I usually try and go with regenerative medicine first. And then if it doesn't work anymore as the disease progresses, then I'll go for steroids.
Thank you.
Yeah.
So,
Any other questions?
well, this is just a comment, and I'm happy to share my experience with this with the club. Keo has pretty bad arthritis, which many of you probably already know, and I'm probably going to have PRP done on her in the next month or two. And I'll ask Chris Fry to make sure he gets videos before and after, so I can show the club.
Oh yeah, I have I think I have about half a dozen videos of her in the treadmill as well as on land, from all the months we've been seeing her. So we've got lots of documentation.
Right, yeah. So if you guys are interested, I'm happy to share that info with you.
All right, let's dive into stem cells. All right, so stem cells is somewhat controversial, depending on who you talk to. So they are undifferentiated multipotent stem cells. So what that means is they can become many different types of tissues. If you look at my little diagram over here, there's many different types of stem cells. So totipotent stem cells are stem cells that can fertilize an egg and create a placenta, form an embryo, things like that. Pluripotent, these just form the embryo, and then multipotent stem cells are kind of everywhere in your body, and they can become different types of tissues, but not infinite types of tissues. There's like certain things they can become. You also can't like grow a person from multipotent stem cells. Cool thing about stem cells, they self-renew, which is awesome. So they just sort of grow and grow and grow and grow and grow. And they can develop, as I said, into these specialized cell types. And their function is to repair tissue and replace senescent or sort of dying or non-functional quiet cells. Some of the characteristics that define stem cells as they move during angiogenesis. Angiogenesis is the formation of a blood supply. They can differentiate into special cell types. They can proliferate and regenerate. And they also release some immune regulators and growth factors, which is very helpful. So as I said, they can become lots of different types of cells. All of these are some of the cell types they can become: bone, cartilage, muscle, marrow, tendon, ligament, adipose. Adipose is fat. And we can get them from many different places. So you can get them from fat cells. You can get them from the umbilical cord if you're there the second the dog is born. You can get them from muscle cells. And you can get them from the bone marrow. So we're not entirely sure how they work. We think it's lots of different interactions, but they certainly enhance regeneration of injured cells. They stimulate proliferation and differentiation of progenitor cells that are already there. So they'll go and sort of wake up stem cells that are already living in an area that we're introducing them. And it will modulate a local immune response. So it's going to help us tone down that inflammation. Again, less inflammation, less pain. And the immune response in a localized area is a big contributor to the progression of arthritis.
Okay.
So we at Cornell pull from the bone marrow. And when you actually collect from bone marrow, there's not that many stem cells. So 0.0005% to 0.001% of the bone marrow that you're pulling out is actually a mesenchymal stem cell. So we collect bone marrow. We also collect whole blood and collect just the serum, that plasma portion. And we have to expand them in a lab. That takes about 3 to 4, sometimes up to 6 weeks. The sites that we can actually pull bone marrow from, this is the femur. This is part of your pelvis. So this is the wing of the ilium. Or you can pull it from the humerus. So this is your shoulder joint. So it is a 2-step procedure. We collect bone marrow at one visit. We send them to the lab to grow, and then the patient comes back once we've grown them and expanded them, and we inject them at that second visit. This again is a chart I borrowed from Dr. Fry, talking about all the different studies that have been done using stem cells. They injected many different joints, but looking at the duration of positive effect, The lowest here is 30 days, up to 60, but it can go all the way up to 180 days. So I tell clients when we're considering PRP versus stem cell that stem cell, there are some studies showing it only lasts for 30 to 60 days, but most of our clinical experience with it is that we see an improvement for 3 to 4 months, and sometimes that can go up to as much as 180 days. The types of cases that we use stem cells for: arthritis, muscle tendon, ligament stuff, bone healing. And there was a cool case study that I found talking about spinal cord injuries. It's something that's being investigated for humans, but there's also been 1 or 2 case reports in veterinary medicine. So this was a German Shepherd, I believe, that had a disc herniate in its back, did go to surgery. They sort of decompressed the spinal cord and removed part of the disc. And then several weeks later, they injected stem cells into the area of that disc and followed up with MRI a few months later, and the hydration of that disc was improved. So it's a new area of research that some people are working on. So our first example is Molly. Molly's a wonderful 5-year-old female spayed golden who was diagnosed with elbow dysplasia and had surgery to debride her elbows back in 2016. She has had many different injections in the past. So she had just PRP in February of 2019. They prepared stem cells. They weren't prepared here at Cornell. They were done elsewhere. That was in June. She had PRP again that November. Then she started coming to see us. We prepared her next round of injections. So we did stem cells here in January of 2020. And then this most recent visit, we did PRP and stem cells together. And that was sort of the end of June. So Molly is a very energetic, rambunctious girl. So when I tell you that this is her being incredibly subdued, you'll have to take my word for it.
I need some help again. Yes.
So at the time of her visit in November of 2020, she was doing very well after her last injection. Her last injection was a combination of PRP and stem cells, and that was done in June. She was doing 20-minute walks on flat ground.
Again.
And she was seeing a rehab vet elsewhere twice a week for some underwater treadmill and some laser. She was also getting supplements to help with her joints.
Helpful.
On exam, she had a 2 out of 5 left forelimb lameness, and she does have a mild head bob. I'll play her lameness video again for you guys to see that. She has very reduced flexion in both of her elbows. Her left side more affected than her right. And she was mildly uncomfortable when we extended her elbows. Okay. So we saw her back in December, 4 weeks after giving her, again, more stem cells plus PRP. And this was her second injection of mesenchymal stem cells plus PRP. Owners reported this is the best she's ever done after injections. She didn't need any sedation or pain meds after her procedure, which usually she does. And she was very energetic at home. So this is more like Molly normally, which you can't actually evaluate her gait, well, for a few steps there, but she's just so exuberant and happy. So she still has a forelimb lameness, but it's improved, and she was much more comfortable as we put her elbows through range of motion. Our plan for her was to gradually increase her exercise at home and to have her continue with her physiotherapy exercises with her rehab vet locally. Our next case is another retriever. I don't actually know this patient's name. This was a Fry case that I borrowed. 5-year-old female spayed lab. She's had 4 years of intermittent forelimb lameness on both sides. It's been progressive arthritis, and her non-steroidals aren't working for her anymore. And she'd gotten PRP in the past, but that was no longer working either. We'll do that again. It was kind of quick. Hello. And you can see her elbows are just not terribly happy. So there's this little spur of bone there, little spur of bone back there. Edge here isn't entirely smooth. Oh, sorry, needle and blood alert. So here we're going to show you some pictures of bone marrow collection. So again, we're very sterile. We drape the area. We use sterile gloves. Everything's sterile. And we introduce this needle. We pull from the humerus. So this is sort of her shoulder joint is probably up here. And we're directing this needle into her humerus. And we're collecting bone marrow. When we send it to the lab, you can see that there's not many of these little cells that we want. They're sort of spiculated looking. 3 to 4 weeks later, many, many more. So this is not an injection of elbows, but this is a hip injection, just so that you guys can see sort of how precise we have to be. So this is the head of the femur. This is the acetabulum, sort of the socket portion of the ball and socket joint that is the hip. And the needle is going to come in from this direction and fit right into this little area here. There's the needle coming in, and it slides right into that spot, right there. And then I think the next video I have actually shows us injecting stuff into the hip, but it's the tip of a needle and it's filling that space. So here's our next one. We switched the direction of the probe for this one, so the needle's coming in this direction. And again, sort of femur head, socket, and you'll see the injectate sort of, it's this white stuff that you'll see sort of in here. So that was them just taking a picture. And then you'll watch here-ish. There it is. There it is. So it's a quick video. I'll play it again for you guys. All right. Questions about stem cells?
Can you hear me?
No, I
Yes.
can.
Okay. So we've got a dog that she went to SOS. So she had a cruciate tear
Mhm.
and they did PRP and stem cells. But he didn't grow them. She was there for about 2 days and he took so how is that different than what you're doing here?
Yeah, so one of the other biologic treatments that I'm going to mention at the end of this,
Okay.
there is a way, there's a different procedure that it does involve stem cells. They're just a much lower concentration. You can collect it from fat. So if you collect fat, and I'll talk about this briefly in a few slides, where you sort of enzymatically digest it and you spin it down and then inject it. Or if you pull bone marrow and you like spin it down in a centrifuge and you pull off like a portion of it and inject
Yeah,
it.
they took it from her bone marrow.
Okay, so yeah, that's what is it? Bone marrow concentrate, I think it's called. And it does have stem cells, but if you recall what I showed you earlier, that, let me see if I can find it, is there's only like 0.001
Right.
percent of stem cells when you immediately pull it out of the bone marrow. So yes, there are stem cells and you can spin it down and inject it. And some people do see a positive response with that. For Dr. Fry and I, if we're going to inject stem cells, we want to just inject stem cells, not stem cells plus the other stuff,
Okay.
Which is why we send it to a lab and grow it. So your dog did get stem cells, but it wasn't only stem cells.
It wasn't. Okay. And it wasn't at a high concentration.
No, if they're pulling directly from bone marrow, spinning it down and injecting it, it's a very low concentration.
Well, it seemed to work.
Good. That's great.
So the stem cells are supposed to stimulate the growth of what exactly in that situation?
In the situation with Lisa's dog where she had,
Well, the one you showed us. Now, it was in its elbow, right? And the dog has some bone abnormalities, so it's not going to change that, correct?
correct. It's not going to change the bone abnormalities. So what we hope for is that it's going to have that sort of local immune response, because stem cells have that capability to tone down the immune response locally. And I'm not making her immunocompromised in any way. It's just in that joint area, and we're reducing inflammation. If the cartilage is getting damaged and things like that, the mesenchymal stem cells do have the capability of potentially turning into cartilage. There's not definitive proof that they will do that if we inject them, but if there is that capability, we know those cells can become cartilage. And if they're in the environment where there might be some cartilage damage, it might help with that. So it's going to definitely reduce our inflammation, definitely reduce our pain. It has the possibility of turning into cells in that area that are damaged. It can stimulate stem cells in that area to repair certain tissues or regrow into certain tissues, depending on what's damaged. So it has a greater capability than PRP, but as far as like what we're clinically seeing, if dogs stop responding to PRP, we'll often try stem cells and they'll have a better response. And as I showed you in Molly's case, we often will combine PRP with stem cells to sometimes have an even better response. I wish I could tell you exactly which patients would respond to which treatment best. Some of it's a little bit of, okay, well, we tried PRP, that helped a little bit, and the owner wants to try stem cells, so we try that and say, okay, maybe that was a little bit better, and maybe we combine the two and it's brilliant. It's a little bit of patient variability.
So at this point, you're primarily using the stem cells to reduce inflammation and not specifically using them to say, we're going to have it stimulate growth and repair this tissue.
Yes, we hope that it will stimulate growth and repair, but I know it will reduce inflammation. Every patient is different, so exactly what the stem cells are doing in each and every dog, I can't completely predict. But by having that capability of modulating the local immune response, as well as reducing inflammation, we have a greater chance of stimulating repair of tissues in that area.
Thank you.
Yeah, of course.
It sounds magical.
It is. It's sort of like science fiction, right?
Yeah, it's fantastic. I mean, this is an amazing frontier. Why wouldn't you use the stem cells all the time?
It is a little bit more expensive. It is 2 procedures. So we have to collect the stem cells and then send them off to be grown, and then the patient has to come back. So it's not a same-day procedure the same way PRP is. What we will frequently do is when the patient comes to have when they come to have stem cells collected, we will inject them with PRP at that point so that they do have a procedure done, not just collecting the stem cells. And then while the stem cells are being stored, and the nice thing is, once we collect stem cells, we have them for life. We don't need to go back and get them again. They just sit in our lab and wait for us to say, okay, we need them. And then they say, great, what concentration and how fast do you need them? And I'll say, okay, I'd like them in 4 weeks and I want them at, 6 million cells in 2 ml volume. And they'll say, great. And then meanwhile, the patient's at home, hopefully doing well with PRP. And when they start to deteriorate again, we say, okay, let's come back. We'll plan it. We'll have the stem cells and we'll inject it then. So 2 procedures. It's more expensive because it is more expensive to collect them and store them. So your upfront cost, and again, these are very rough numbers, is around $3,000, whereas PRP is, $400 to $600. And then when we actually grow them out and inject them into the joint, that's probably around $400. So it is a bigger financial commitment. But yeah, if owners are willing, we love doing stem cells.
Yeah.
Can you can you only use the stem cells in the dog they came from, or can they be used in other dogs, or, you know?
We only use the stem cells that came from the dog. There's always the potential for, infection when you're injecting a joint or a reaction, but that the safety profile of using their own cells is incredibly safe.
Yeah.
There has been some work done where they'll use stem cells from a different dog. Sometimes it goes great, but if they have a reaction, it's just something I'd rather avoid.
Right.
All right, I'm going to move on unless anybody else has questions about stem cells.
Well, I have Keo specific ones, so we can talk about that offline.
Yeah, I love to talk about Keo. All right, so these are the other blood-derived biologic treatments. We don't do them here at Cornell, but you'll definitely hear about them if you spend enough time around sports medicine people. So the first one we're going to briefly talk about is autologous conditioned serum, ACS. If anyone's from the horse world, they may have heard of IRAP. It was very, very popular 5 to 10 years ago. It's still used a lot. IRAP stands for Interleukin Receptor Antagonist protein. So what we do is they pull blood into a nice big syringe that has these little beads in it. The beads can be either glass or borosilicate, and it's incubated with these beads for anywhere from 7 to 24 hours. When I worked in equine performance practice, we incubated them for 24 hours. And while they're chilling with these little beads, it activates leukocytes, which release interleukin 1 or IL-1. Then we stick them in a centrifuge, spin it down, collect the fraction that contains this IL-1A, so interleukin 1A, and that's what we inject into the joint. And the reason for this is that IL-1A blocks IL-1B, which is a big signaler for arthritis and pain. So we're sort of blocking it. And it's typically used in patients with OA. It was used a lot in equine medicine. I think it was done once or twice in dogs, literally like 1 or 2 dogs. It wasn't terribly popular in the small animal community. And as far as I know, it's still not used that often, but it pops up every now and again. Another one is autologous protein solution. So for this treatment, you make PRP, same way that we talked about before. Then you filter it through polyacrylamide beads. And what this does is it concentrates the leukocytes, platelets, and plasma proteins. And in humans, it's been found that there's an anabolic and anti-inflammatory cytokine response that lowers catabolic meaning like consuming cytokines. So again, this was done in people. No one has looked at this in canine blood. So again, people that use this in dogs were sort of extrapolating from human medicine, which we do all the time. But there's very limited research using this. Finally, this is, I'm afraid I don't remember whose dog had stem cells while they were at the vet place for 2 days, but this is probably what they were doing with stromal vascular fraction. So they can take it from adipose tissue. Oh, wait, you said it was from bone marrow. My mistakes. That was probably bone marrow aspirate. So for stromal vascular fraction, you go in and get some fat tissue. Usually they use the falciform ligament, which is this big fatty thing sitting in their abdomen. You then digest it with enzymes, filter it, and this is your stromal vascular fraction, and you inject this into the patient. About 8% of those cells meet the most lenient definition of stem cells. So there's probably some stem cells in there, just not all that many. It's also more invasive because to go and get the falciform ligament, you have to enter the abdomen. So they are going in for abdominal surgery to grab this little piece of fat tissue. It's pretty quick. They go in, they grab it, they close and they come out. But you are entering an actual body cavity. And that is all I prepared for you guys. I didn't want to keep you too long. Any other questions I can answer?
It's really, really interesting.
It's my favorite part of my job.
So how do you, I know it's a case by case basis, and of course I have Keo in the back of my head. How do you determine whether a dog should do PRP first and then stem cell or both?
Mm-hmm.
What's the
We always,
criteria you use?
yeah, so we always start more conservative. I also take the age of the patient into consideration. So particularly for young patients where we, if I'm treating them at 8, 9 months or a year, and we know this is going to be a progressive condition for their entire life, I will more strongly suggest stem cells simply because once we do that initial collection, we have stem cells forever. Um, and for a younger dog where we're going to be potentially doing this sort of over and over again, I like to use stem cells. That's not to say that PRP is, it's very valuable. We use it a lot. So if people are unwilling or unable to meet the more, larger financial outlay for stem cells, we do PRP. Some people like to see how they respond to PRP before jumping to something as expensive as stem cells. And over time, patients, as their disease progresses, will become less responsive to therapy. So, if they've been going along great for 5 years with PRP and then suddenly they're not responding as well, then we have a conversation of, we might need to try something different.
Does the same thing happen with stem cells, that they'll stop responding after a while?
It's always possible. I have not seen a patient yet that hasn't, if they've stopped responding to PRP, the patients I've treated have responded to stem cells. But yes, theoretically they could. As I said, I can't completely halt these progressive conditions. I'm just trying to slow them down as much as possible.
Margaret, do you know of anybody doing research on any of this for IVDD, intervertebral disc disease?
Yeah. So I mentioned the case report of the German Shepherd with
Yeah,
IVDD,
that was just the one.
with the stem cells. I have not gone back to look to see if there's anything else. Lots of people are working on this stuff, but sometimes it doesn't get published. We do have a doctor at Cornell that has, her lab is dedicated to stem cell research and PRP and sort of regenerative medicine. I went to vet school at University of Pennsylvania, so there was a large animal surgeon who had a particular interest in regenerative medicine.
Yeah,
So I know
Dr.
she's
Fortier.
doing a lot.
I work there. I work in a
Oh.
large animal hospital.
Oh, perfect. So specifically for IVDD, I don't know. I'd have to go and look. And sometimes it's on a single case basis.
Yeah.
If somebody's really involved and really wants to try this, sometimes it'll be sort of a one-off, hence the case
Yeah.
report. But off the top of my head, I do not know anyone that's running a large scale
Yeah.
research investigation into IVDD. That doesn't mean it doesn't exist. I just
Right.
don't know about it.
I know there isn't at Cornell, because my
No.
dog's been there, and but I just wondered if you knew of any place was looking into it, and is it something maybe an up and coming thing for IVDD?
Yeah, I mean, it certainly has the potential to be used for
That
it.
sounds like it, right?
It certainly could be. That's kind of the coolest part about these therapies. We're just starting to really get to use them. So their potential, we really don't know where the end point is for them. So they absolutely could be applied. Stem cells in particular, because they can become these other types of tissues, might be more valuable. So if you have a dog that has herniated discs, maybe you could inject stem cells into those discs to try and reduce degeneration. So if you do an MRI and you find a whole bunch of discs, maybe in the future this is something we could go back and introduce stem cells to prevent them from herniating, or at least delay them herniating. So I heard about stem cells being used for disc disease. I have not heard of PRP being used for it. Again, stem cells have a much greater capacity to therapeutically repair tissue because they can actually turn into those tissue types. But yeah, no, it's the research out there, it's coming. Sometimes it just takes a bit of time.
Yeah. Okay, thank you.
Yeah, anytime.
Thank you.
It's my pleasure. Thank you guys for showing up.
Thanks so much.
Mhm.
Very interesting.
Excellent talk. Thank you.
Oh, I'm
Thank
glad
you.
you guys liked it.
Very interesting.
Yeah.
Very interesting to me because of Keo. You know, I sort of saw back and forth about getting the stem cell. She's going to be 10 soon. And is that, it seems like a lot to ask for an old dog.
Yeah, I mean, they generally recover quite well from the collection, but it is more. So instead of just having a simple joint injection, you know, we're working in 2 different sites. Takes a little bit more time.
And
So-
then the other issue is, you know, she's got so many joints that are funky. How do you decide which one or 2 or 3 to address? How do you decide?
Yeah, we always pick the one that's affecting them the most.
And do you do more than one at a time?
We usually do a pair of joints at a time. So like if we're going to treat elbows or we're going to do hips, we'll pick like a pair of joints. Sometimes we're only doing one joint. So if we have a cruciate dog, we're not going to inject the healthy
Right.
knee. We're going to inject just the knee that's affected.
Right. And you
so
do
yeah.
the same, you do the same joint bilaterally. You wouldn't do like a hip and her elbow, for example.
We could if we think that her 2 biggest areas are, you know, her one hip and her one elbow. It's not a hard and fast rule, but we pick the areas that are most affecting them because I don't want to be
Sure.
sticking needles in
Right.
secondary places. So yeah, and we always try and start conservative. So we always start with, hey, what does rest and meds do? Okay, what does rest and exercises do?
Well,
And
we
sort of work
have a
over
lot
that.
of information on her already.
Yeah, but I never jump to, great, you're here, let's stick a needle in it. It's always, okay, like, do no harm. What can I do while impacting the patient minimally?
Right. Which will
Sometimes they
hopefully-
come in and I'm like, oh, we really should do PRP and you drove 6 hours to be here. Why don't we do it today?
Yeah.
So it depends.
Yeah. Well,
Yeah.
I say this and think this a lot. I just feel so grateful that we're so close to the might and resources of a major university with a major med school. I thank the gods of dogs.
Yeah, well, I mean, there's a reason that God is dog spelled backwards, right?
I gotta tell you, every time I type out dog, I'm typing G-O-D. Like, wait, is that Freudian or what?
Yeah, no, if someone invents the Church of the Dog, I am totally signing up.
Me too. Thank you so much for doing this for our group. I know that people really appreciate it. I'm quite happy that, wow, we had a big turnout.
Yeah,
And
yeah,
sorry
like,
for the error with my,
it's all right, we got there.
Yeah.
We got there in the end, but yeah, thank you guys for showing up. This is probably my favorite part of my job, and I think it's just going to get more and more interesting the more we learn and the more cases we treat with this stuff. So
Yeah.
I'm
Well,
glad to have a receptive audience.
You'll be doing Keo sooner or later. I did get a PEMF mattress for her.
Oh yeah, that's right. Did you get the mattress or the Assisi loop?
I got the mattress
Okay.
because I figured that the mattress was how do you get the Assisi loop around around her hips, right? And
Yeah, you sort of lay it on her and you hope it's angled just right. And
Yeah,
no,
right.
the mattress is nice. Plus she'll like a cozy place to curl up.
Or she doesn't like it, right? It's not soft enough. So I
Oh.
told them and they said I can put her bed over it, but she doesn't like the lump in the middle. So I put it, she has multiple beds and I put it on the bed that she usually sleeps on at night. And I wake up in the middle of the night, is she on it? I turn it on.
Yeah. Sometimes you can bribe them to stand on it or lie on it for like 20 minutes so they can have like a 20-minute treatment.
Yeah, no.
Yeah, you can only suggest, you can't make them do it, but you can try.
Especially her, Sue Yanov, I don't know if she's still on. She says, she talks about old dog immunity. Keo can pretty much do whatever she wants at this point. She's done so much for me, so she's definitely got old dog immunity.
Yeah.
When she
Like
does
my
something,
friends in vet school, they were vegans themselves, but they'd be cooking their dog steak. And I was like, this is love.
yeah, well, you care about your dogs. I've had geriatrics that I've made hamburger helper for, and I have vowed, we are never having that in the house. And there I am.
Yep. Yep.
All right. Well, thanks again.
Oh, it was my pleasure.
Really
Thanks.
appreciate it.
Yeah. Thanks, guys.
Have a good night.
Thank you. Bye.